Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for health professionals in Aotearoa, New Zealand. In this series, we look at key medical legal issues in our jurisdiction. And today we're focusing on HDC cases involving the use of medication. So look, I thought I'd start with some background and looking at a study published in the British Journal of General Practice in 2021 that looked at medication-related harm in general practice records over a 2-year period. And they looked at 8 GPs looking at 9,000 patient records and looked at medication-related harms that they could identify when the causal agent had been prescribed in general practice. And they found that 10% of the patients reviewed experienced 1,762 medication-related harms over that 3-year period. So that's a huge number. The incidence of preventable or potentially preventable medication-related harms was 15 per 1,000 patient years, which is essentially if you've got a practice of 1,000 patients, that means that potentially preventable harm due to medication has occurred in 15 of your patients each year. And 20% of those harms were moderate to severe. And in the cohort they looked at, 3 patients actually died, 18 were hospitalised. They noted that increased age, number of consultations and number of medications was associated with an increased risk of medication-related harm. Particularly, they looked at cardiovascular medications, anti-neoplastics and immunomodulatory agents and anticoagulants as being the ones that cause the most harm by frequency and severity. And actually, there's similar hospital data. A 2017 study where data was gathered from 8 DHBs showed that harm occurred at a rate of 34.7 per 100 admissions, so 42 per 1,000 bed days, and 28% of patients experienced one or more medication-related harms. So again, really huge numbers there. They noted that those harmed by medication are more likely to be older, female, and have an increased length of stay. And most of those harms, 65%, occurred during inpatient stay. So that's the background. My name is Lucy Gibbard. I'm one of the medical consultants at Medical Protection, and I'm joined today by my colleagues, Dr. Tim Cookson. Hi, Tim.
Hi, Lucy.
And Dr. Sam King. Hi, Sam.
Hey, Lucy.
And also by our colleague from our panel law firm, Mr. Adam Holloway. Hi, Adam.
Hi, Lucy. How's it going?
Very good. So look, those stats about medication errors are really frightening, aren't they? And when you look at the numbers, it's actually amazing that we don't see even more complaints about medication issues, and that's even though we do actually get quite a few. So I don't know, have you had any cases with significant medication issues, Tim?
Well, I can report a personal case.
Okay, you can do that.
Who did you prescribe for and what did you do wrong?
Well, I did everything wrong, really. So this was a lady who was on a complicated methotrexate regime prescribed by her dermatologist. And there needed to be some alteration of the regime, and the dermatologist wrote to me, and I rewrote the prescription, but of course did the classic error, and there have been a number of deaths because of this, that instead of writing whatever the dose was weekly, it got put in as the dose should be taken daily. And I didn't realise at the time, but I got a call the next day from the patient who'd happened to be up in Tupō, who said, "Oh, Tim, look, I think you might have made a wee mistake with my prescription." And I looked at it and just, cringed inside and just shocked at how easy it was to make that mistake. And, my excuse was, it was a complicated regime. I was changing it around. I was focusing on that and not on the weekly versus daily. But we certainly had 2 cases some years ago of patients dying from methotrexate
Daily
poisoning.
methotrexate.
Yep. And so it's a very real risk.
It's simple human error, isn't it? When you've got a whole list to do and you probably don't have a lot of time to do it, it's very easy. And, I've had cases where it's just been you have the drop-down box.
Yeah.
And it's just the wrong click. It might be the wrong medication. It'll be, instead of the doxycycline, it's the doxepin or whatever. And it's just so easy to do. And I think we're very fortunate in that often the pharmacists pick them up from primary care. I often get called from the pharmacy next door, challenging or questioning me about the doses and things, which I'm incredibly grateful for, but it's so easy to do. And unfortunately, significant harm does happen. hospital cases where, someone's been prescribed a drug they're allergic to. Easy thing to miss if the drug charts haven't been filled in right by the admitting house officer. It's just easy peasy. That's why there are so many, I think.
I think one of the hardest ones for me is actually when the patient's EGFR is dropping.
Oh,
and
you
haven't gone back and checked on NZF what the dose is for that EGFR, and you've just clicked repeat, and then suddenly you look at it and you think, oh dear, their EGFR's under 30 now. What should I have changed? And it's taken you a little while to realise that that's actually a change because you just repeated them.
Well, in lots of situations now, you've got other doctors who are doing the repeat prescribing for their colleagues. That's all they do. They do the inbox, they do the repeat scripts. And so I think a lot of us, when you're just doing a repeat scripts, that you take it casually.
And look, the first case that we're going to look at from the HDC is actually a case like that where, there was something in that NZF that maybe many of us wouldn't have even been aware of. But in this particular case, it made a huge difference to the patient. So this is a missed opportunity to ensure a man understood the risks of taking nitrofurantoin for an extended period. And in this case, the patient was paraplegic and was managing his neurogenic bladder with intermittent self-catheterization. And because of that, he had ongoing urinary tract infections. And he was initially prescribed nitrofurantoin by a specialist at a spinal unit as a prophylactic dose. The medication was successful in treating his symptoms, and both his GP and the urology registrar at another public hospital continued to prescribe it without ensuring that the man understood the risks of long-term usage. The pharmacy also dispensed the medication without advising the man of the risks. So the man took nitrofurantoin for around 28 months over a 3-year period and was never made aware of the known risk of pulmonary disease from its long-term use. Consequently, he didn't have the opportunity to make an informed decision about whether the potential benefits outweighed the risks of continuing to take the medication. He died of fibrotic lung disease caused by the medication. So the HDC got a GP expert, a pharmacy expert, and a urology expert to look at the case. And they all agreed that when the use of nitrofurantoin exceeded 6 months, Mr. A should have been told about the potential long-term risks so that he could make an informed decision about whether or not the benefits of continuing it outweighed the risks. Although I am very critical that none of the health service providers who cared for the man ensured that he understood the risks, I consider that no individual or service was significantly more responsible, was the HDC decision. So what do we think about that? The culpability of the doctors who are repeating a script rather than the one that initiated it. I mean, there wasn't a documentation in this about the length that it was to be used for, but there wasn't any warning that it was to be stopped either. So I don't know, how do you feel about that, Sam? What do you think about when you hit repeat on something that's been started by a specialist?
I think the thing to remember is that every time we sign a prescription, we take responsibility for it, whether it's simply a repeat or whether we're prescribing for the first time. And I think in the HDC cases that I can think of, it's a common problem where it's not necessarily the initiating doctor, but it just happens to be the one who the regular GP is away and I'm just going to prescribe this for you. Let's just keep it going. And we do it without necessarily thinking about it, stepping back and thinking, is this appropriate still? And, in good medical practice.
Do we as repeat prescribers, Tim, do you think it's reasonable for us to rely on the fact that the initial prescriber went through all the possible side effects of a medication with them? Because that's the case here. If that initial prescriber had gone through all the potential side effects, can the next doctor rely on that having happened?
We tend to, is the answer. And I guess the difficulty here is, as you pointed out, when it was initially prescribed, what was the intention of the doctor who prescribed it? Was it as a long-term prevention? In which case, yes, you'd expect that doctor to say, look, there's a risk at 6 months that, of fibrotic lung disease, so you need to consider that. But that doctor might have only intended for him to take it for 2 months and then see what happened. The difficulty, and I think the HDC was correct, was that the subsequent doctors who would have known that he'd had longer than 6 months all of them must have assumed that someone else had had the discussion with him about the potential risks, or they didn't know. And actually, that's another factor. Mostly nitrofurantoin is prescribed short-term, very low risk profile, and you don't even think about it. And it's one of those things that you might read about, think, oh, I should remember that. But then amongst all of the other information that we have to deal with, it just goes to the back of the mind and doesn't come to the surface again. And so it's quite possible, and I think, as the HDC found, some of the prescribers actually were not aware of the risk.
I think there was something that came out a few years ago from MedSafe around this. But prior to that notice coming out that I happened to read, I wasn't aware of it either. So it is, and you think about the volume
of things
yeah.
And the other thing is I think one of the problems with this particular one is how commonly we use nitrofurantoin. It's a common drug in a short-term case. So you kind of get used to what the short-term side effects are, and you don't open NZF to look at the long-term side effects because it's just not in your head that actually that's something that could be there. You can just see how this happened. And I think, as you say, the specialist that started it may not have intended it to be a long-term use, so may not have talked about it.
I've got a case at the moment, I obviously don't know where it's going to end up yet, where a coroner has been asking about codeine prescribing, and when the patient was warned about its addictive properties, etc., and the risk of, for physical dependence. And fortunately, in this case, the patient was warned a number of times, and it was documented as such. But you talk about, long-term pain medications. Similarly, how many times do we warn about these things? I think not very often.
Yeah. And look, it's interesting. The HDC's opinion here was that all healthcare providers who had a role in the prescribing and dispensing of nitrofurantoin to the man could have checked whether he was aware of the long-term risk at appropriate times. And it's concerning that this did not occur. So the HDC is saying everyone who signed a script has got a responsibility. And then you think, goodness, that's the onus on that repeat prescribing is so serious, isn't it? It's something that you do on a very regular basis, and it just shows if there's a medication that isn't something that either not one you're normally using or is being used in a way that you're not commonly using, then you actually need to check.
And you're often in a difficult situation too, aren't you? Because you've got a patient who has an expectation of getting a medication, but you may not actually agree clinically that that's the right thing to do for that particular patient when you're signing that repeat prescription. But what do you actually do about it? It's already been prescribed, the patient thinks it's working, and you're not actually really involved in their care. You're just signing the repeat prescription. It's a difficult situation to be in.
I think that situation you say no if you don't think it's appropriate.
I agree.
As soon as you sign it, it's yours.
The other possibility is whether you just sign it for 2 weeks until their regular GP comes back.
Yeah.
I think that's a good point, Sam, is that there may be other options for either repeating for a shorter period of time or putting something in the notes. I think it's asking a lot of the patient to say that a warning they might have been given by the first doctor, that they've fully understood it and somehow are taking their own responsibility for that. I mean, I've certainly been part of cases where a medication that would have been fine for a while, like a topical corticosteroid, becomes very not fine if it's just continued on and on and on. And relying on a patient who it might be having the desired effect and has become even in you're dependent on it in a sense, and advocating for it is not going to be the person sort of voluntarily deciding to take less of it. But if you're doing a repeat, and as Sam said, do it for a shorter period of time, or communicate back to the usual doctor, just checking.
Yeah, just checking. Did you mean to do? Is there a reason?
Has there been a conversation or thought about how long that this medication has been prescribed for now? I note the risk of X.
Yeah. I think the problem in this case actually was that actually some of the doctors just weren't aware of the potential side effect. And so they didn't tell the patient because they didn't know themselves. Interestingly, the HDC didn't breach any individual doctor here. They just looked at what the doctors in the practice had done to try and avoid this in the future, and also made some recommendations for information to be disseminated by the College of GPs and Health Quality and Safety Commission. So, as Sam was saying, trying to get it out there for doctors to be aware of it. They also thought about, interestingly, whether Pharmac should require a special authority for prescribing beyond 6 months, which is an interesting thought, isn't it? That actually using Pharmac as your regulator almost to stop people doing long-term scripts. The other thing they wrote is, in addition, the Medical Protection Society casebook is widely read by a range of medical practitioners, and an anonymised article highlighting this particular case would provide good penetration. So they've invited us to write about it, but I thought we'd put it on a podcast. We could write about it as well. Anyway, I thought that was a very interesting case and just highlighted the issue of repeat prescribing, basically. So the next case that we looked at from the HDC was about the consent for the administration of steroids, a report from the Deputy Commissioner of the HDC. This is a patient who had neurological symptoms who required spinal surgery. And prior to the initial surgery, the operating surgeon was changed. And the surgeon stated that he met with and discussed the proposed approach with the woman, and she has no recollection of being informed of that change. After the initial surgery, the woman did not improve and her symptoms actually deteriorated, so further surgery was arranged. Following the second surgery, the woman was prescribed and administered dexamethasone, although the woman said that this was never discussed with her. After the events, the woman made a complaint directly to the hospital, but she experienced delays in contact to update her on the progress of the internal investigation. So it's the Swiss cheese thing, one thing after another as well. There were several issues in this case, but we're going to concentrate on the issue of the prescribing of steroids. The case notes there was no discussion documented regarding this prescribing of dexamethasone. The Deputy Commissioner considered that this reflected the pressured environment in the service. As hospital responsible for the care, hospital was found in breach of the code because of the lack of documentation. Also in breach because of the lack of information provided, and also in breach for the lack of consent. So the fact that this woman wasn't told about being given dexamethasone was breached on three different parts of the code. The patient had actually had 2 spinal surgeries, and after the second one, she had been given the dexamethasone 2 milligrams twice a day for 3 days. She said that it wasn't discussed. The clinical notes don't record a discussion. And the hospital said that dexamethasone was just something that's routinely used after surgeries of the spine and brain to reduce inflammation if there's any suspicion of swelling. They also said that sometimes they use it at induction or intraoperatively, and sometimes it's continued post-operatively. The doctor who actually prescribed it couldn't even remember and thought he prescribed it on the advice of a consultant, but it wasn't documented, and nor was any discussion with the patient. The doctor did comment that the department was very busy at the time. So the HDC has said, in my view, in the context of this case, this is an error for which the hospital must take responsibility. I consider it reflects a pressured environment in the service, as the hospital has overall responsibility for the service provided. Therefore, this aspect of the patient's care, it's going to be the hospital that's been found in breach of the code, because she didn't give informed consent for the administration of the steroid, and it wasn't discussed with her. So I thought this was quite interesting, because you actually give patients all sorts of medications along with their surgery. Some of it is very protocolized. Does there have to be a record of informed consent for every medication that is used for the patient when they're in hospital?
Really harsh, Lucy, that decision. You're going to be given all sorts of medications as part of the procedure of undergoing surgery. And when you're trying to prioritize what to focus on, when you're giving a patient a lot of information in an informed consent discussion context, I think understandably you're going to be focusing on what the procedure involves, what the risks of it going wrong are, how long it's going to take to recover. To sacrifice time, part of that conversation, to say, and now I'm going to go through a list of all the anaesthetic drugs you might get given.
And all the possible side effects of all of them.
Is asking a lot of the system. And maybe one way to respond to it, I mean, if this is the sort of defensive posture we have to take, would be to review informed consent forms. And I know, just having a signature on a form doesn't necessarily get you home. But if it says, we've discussed the procedure, we've discussed what it involves, are you happy to take all of the normal medications that we would give a patient in these circumstances? Something like that, just to show that you've raised it and at least given an opportunity for them to say, no, I want to talk about them each individually. That was the only sort of thought I had in response to it, but it does seem quite harsh if it's a standard protective medication that you would give all patients in that context.
I'm not sure in this case whether it was actually given at a time post-op when they thought it would be helpful for her symptoms. But they were saying that actually sometimes they just use it because they're trying to reduce swelling. And you kind of think, so if you're giving a patient a pain relief after surgery to try and reduce their pain, we would normally say, you'd normally tell the patient what the pain relief was and why you were giving it.
Not that they're necessarily competent at that point post-op anyway. Having just come
true,
out of
actually,
anaesthesia.
isn't it? Yeah,
Maybe it's treat them under Right 7-4, best interest, because they probably aren't competent just straight out of theatre, waking up.
That's true. I thought this was a really interesting thought about how practically in our current public healthcare system that we can actually uphold the Code of Rights if that's the level of expectation, to talk about every medication's possible side effects and get informed consent and document it. It does seem like that would be a lot of work.
Yeah.
There's a few interesting things here as well, aren't there? In that I'm guessing that the complaint was not so much about the dexamethasone, though it was a bit that the woman obviously raised, but it was about the fact that the initial surgery didn't go right, and therefore she had to have a second surgery. And then another thing that we commonly see, which is that a complaint has been made and the authority receiving the complaint has not dealt with it in a timely fashion. And if you want anything to annoy your patients or your complainants, then that's going to be the thing that'll do it, not responding in an appropriate time.
Yeah.
And so, maybe if they had responded appropriately and quickly, that would have been the end of the matter. But she was clearly unhappy and got more unhappy.
Yeah. And I think that we do need to be aware when we're prescribing a new medication for a patient what a reasonable consumer would expect to be told about that. I just think it's very harsh if there has to be documented informed consent for every medication. And I don't know if there is anything particular about dexamethasone that made it necessary to do that. I think there are some medications definitely there's a greater obligation to be very careful to properly consent for. But I just thought it was quite an interesting finding from the HDC here, and makes us think about, well, every single medication you write down, you've got to make sure the patient's happy with it and wants to take it and has had an opportunity to ask about it.
And you've got to document it.
You had
the discussion, and we were talking previously about whether there are breaches for poor documentation or lack of it, and this is an example of one where that's happened in conjunction with the breaches for a number of other things at the same time.
What you could do is you could get a 500-page booklet
with every drug in it.
Every drug, the entire procedure set out, including what kind of sutures you're going to use, and give it to the patients a month ahead of time. And if they have any questions, they can go back to you.
But you'd be expected to sit down with them and document that you discussed every page of the 500 pages.
Yeah, it is unworkable.
The other thing that I actually thought that commonly happens from my understanding in hospital is when there's something going on with a patient and they ring and say, oh, look, she's got terrible nausea, can I give her some ondansetron? the nurses ring and you do a verbal order for something, or we do that in general practices, do verbal orders for things. And in that situation, you haven't actually yourself sat down and consented the patient. So you don't know if the nurse is going to, it shows that the obligation when you're essentially prescribing, even if it's by verbal order, is still there. Yeah, it's a bit of vulnerability, really. Okay, so the last case that I thought we should talk about was one where the incorrect medication was dispensed. Now, this case was actually about a dispensing error rather than a prescribing error, but it could have just as easily been a prescribing error. So that's what I was, the aspect that I was thinking about. And it's about two drugs that sound similar in their names getting muddled up. And look, I know I personally have assisted members with two muddled up drugs with similar sounding names. And as Sam said, that doxycycline, doxepin is a case that we've had. I've had a one where a patient was given lorazepam instead of loratadine. There was also one where a patient was given amitriptyline instead of amiodarone, and amlodipine and amyloid. There's so many different drugs, and especially with our prescribing system where you put in the first three letters of a drug and it gives you a drop-down list, and all the drugs with that first three letters or have that three letters in it, it's just so easy to click on the wrong drug. So in this particular situation, Mrs. A visited the pharmacy to collect her prescription, which was for Provera and clomiphene, which had been prescribed by a doctor at a fertility clinic. The clomiphene was prescribed to be taken starting on day 3 of her menstrual cycle, and she collected her medication from the pharmacy. But when she returned home that day, she noted that she'd received clomipramine instead of clomiphene. And she called the fertility clinic, who confirmed that she had been given the wrong medication. She returned to the pharmacy and they arranged to get the correct medication. So she never actually took the incorrect one in this particular case. And the pharmacist was found to have breached the Code of Rights. And I kind of looked at that just because it was so easy to do, and it could just as easily have been the doctor clicking the wrong medicine as the pharmacist picking up the wrong medication. So I was thinking about that, how do we know if there are documents, did you know there are documents of lists of sound-alike medications? I actually went through some of them to actually have a look at all the sound-alike medications. And these things are something that I think we should all just basically be aware of. I don't know if you guys have had any thoughts on that.
I've never had a look at that, but I think you're right, it's very common. And I think for all of us who do prescribe, it is about having that 2-second check. I mean, it used to be that we'd give a paper prescription to the patient, and so you could have a quick check as you hand it over. But now it's all electronic. You just click the button and there it's gone. In fact, half the time I have to check it's even gone because it's like I think I clicked the button, I'm not sure. And you can't tell. But I think it means just that 2-second check to say, is that the appropriate medication that I've prescribed?
I had a case where the patient was given fluticasone in the wrong form, a nasal spray rather than an inhaler, and the doctor didn't notice it. And interestingly, when in the response for that one, we were thinking about how do you check it when it's electronic, where you don't, often on the electronic line of the medication, you can't actually see the form of it. You only get because it's too long and you only get the first bit. And I wasn't aware, but in some of the PMS systems, you can actually click and look at the PDF before you actually hit that send button for the prescription. So you can actually choose to look at the PDF before you send it, which I thought was quite a good hack if you need to check. But the reality is that if you're doing that on every single script, it's obviously going to be a very time-consuming thing to check the PDF of every script before it goes. But that is one way of checking, because we used to have the check of seeing it as you of signing it as you handed it to the patient, and we've lost it. It would be really interesting to see if medication errors have changed since we went to electronic prescribing, whether there are more mistakes. I don't know. I think so often, I was looking at this one, I was thinking so often we get helped by the pharmacist, or the patient, as in your situation, where we've made an error. And I can think of lots of errors that I've made where somebody else has picked it up for me, and so it's never turned up at the HDC. But as I was talking to a member recently, the HDC breaches nearly everyone who makes a medication error. It's almost universal, isn't it? If you've prescribed the wrong drug, that's the wrong drug.
I also wonder what happened when she went back to the pharmacy and how the pharmacy dealt with that. Because it's actually unusual for someone to complain that there's been no harm. She picked it up, she went back to the pharmacy, got the right sort of medication. So that's not a usual response to then lodge a complaint with the HDC. So, you wonder, did she already have a grief with this particular pharmacy? Had already had poor service from them and thought, right, well, that's it. They really made a mistake this time. Now I'm going to complain.
Or what the communication was at the fertility services provider, because she phoned them first.
Yes.
And if the message she'd got from them was,
oh my God, they did what?
Appalling. Or you do take your cues from those sorts of conversations. It's hard to know how it played out, but eagle-eyed of her to pick it up, though, as a patient.
Or it could have been that the pharmacy, when they became aware of the problem, didn't treat it with the significance that they really ought to have, and saying, oh, look, terribly sorry, this was a significant mistake. What we'll do is we'll take some steps to make sure that we don't do that sort of thing again, because, in almost every complaint that we see to the HDC, somewhere in it says, I just want to make sure that no one else suffers from this sort of thing again. So when we can proactively do that kind of checking, I think patients do genuinely get a bit reassured and therefore less likely to complain.
Yes, so there you go. That was 3 HDC cases on medication errors. And look, I think it's a good thing to keep in all of our heads that it's actually a really important part of practicing medicine is prescribing medications, making sure we've talked about appropriate side effects, that when we're repeating a script that we've checked in with the patient, that somebody has discussed the possible side effects with them, looking at very carefully about what we've prescribed. So I don't know if any of you have got any other comments before we sign off.
Well, I think, Lucy, you pointed out how valuable pharmacists are for GPs and the importance of having that good relationship, particularly if you've got one pharmacy that you deal with a lot, and ensuring that they know that you want to know if there's been anything that you've got concerns about, and that you receive any communication about it positively rather than negatively.
It's one of the things we talked to the registrars about, that actually generally GPs are told not to take calls during their clinic time, apart from when it's a pharmacist, because they're going to be saving your bacon. So it's really important to talk to pharmacists. So thank you for listening to this podcast. I hope it's been helpful. Our next podcast will be in a couple of weeks' time. So I hope you'll tune in for that. We look forward to catching up with you then. If you like Medical Protection podcasts, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org.